Conditions which override the CHA2DS2-VASc score. So you don't do the CHA2DS2-VASc, you just anticoagulate. If patient has hypertrophic cardiomyopathy, they have a 4-time risk of clotting, increased risk of clotting. Mitral stenosis have a 20-time risk of clotting. Now here's another scoring system you can also use. It's called the HAS-BLED score. This gives you your risk of bleeding. And it gives you, and this you can use this to give information to talk to your patients about what the risk of bleeding is in taking these. And it gives the risk of, so this is a good website if you consider going to. It's called Spark Tool. It's spelled S-P-A-R-C Tool, sparktool.com. And what this is you can program in the patient's risk factors. From these risk factors, you can give the annual risk of stroke, annual risk of major bleed. And he talks about everything from DOACs to aspirin and other therapies for anticoagulation. So this is the HAS-BLED score, risk of bleeding. Rate versus rhythm control. Rate versus rhythm control. So the old maxim was rate control, was no mortality or stroke reduction benefit is associated with restoring a sinus rhythm, even with those in heart failures. What was the reason for this? The reason is that the antiarrhythmic medications have side effects and they can cause harm. But now we can get if we get the ablation done earlier, we can treat these patients, have them do better. Thus, the symptomatic patients can be managed with a rate control with a goal heart rate less than 110 beats per minute. This is where it's important. Asymptomatic patients. No mortality or stroke reduction in those associated with restoring sinus rhythm, even those with heart failure. Thus, the symptomatic patients can be managed with our goal heart rate less than 110. Okay. We'll talk about why this has changed. And what medications can be used as beta blocker, non-diphenhydropurine calcium channel blockers, and digoxin. And what are those? Those are verapamil and diltiazem. What's the side effects with these? Peripheral vasodilation. These also particularly affect the sinoatrial and atrioventricular nodes, resulting in negative chronotropic heart lowering, rate lowering, but they also can have inotropic. So they decrease the contractibility of the heart. In symptomatic patients, despite rate control, rhythm control became considered with antiarrhythmic medications or cardioversion. The pill in the pocket method with flecainide in patients without AV nodal dysfunction. Flecainide works by slowing intracardiac conduction, particularly affecting the His-Purkinje system, and has a dose-related effect on suppressing premature ventricle contractions and ventricular tachycardia. Patients taking a beta blocker 30 minutes prior to their antiarrhythmic agent when they feel symptoms coming on. So this is pills in the pocket. Subclinical hypothyroidism, there's a 5-fold likely of atrial fibrillation. Remember, subclinical is we have a low TSH and a normal T4. So what changed when we talk about this? Early rhythm control. Multiple studies, and this is progressing more and more. This is a large study, 135 centers, 2,789 patients with early atrial fibrillation, so diagnosed within 36 days. This is where it's important. Early atrial fibrillation. The reason why is we discussed it, is you have cardiac remodeling and fibrosis. So once the egg is cooked, there's not much you can do with it. So you want to get it early. You want to get it in there early and fix this. In patients with primary safety outcome, the event did not differ significantly between the two groups. Serious events related to rhythm control therapy occurred in 4.9% of patients assigned to early rhythm control and 1.4% in patients assigned to usual care. Symptoms of the left ventricle at 2 years did not significantly differ between the groups. Okay, so this is where early rhythm control. Now, let's go with this. Let's talk about this. Early rhythm control therapy was associated with a lower risk of adverse cardiac outcomes than usual care among patients with early atrial fibrillation and cardiovascular conditions. All right, so the treatment has gotten better. We've gotten better ways of doing ablation. There's less risk with ablation. Now we're going to talk about the risk of ablation. It's gotten better. The other thing too is the antiarrhythmic drugs are not, I'm not going to say they're not good. They have side effects and they can cause dysrhythmias. An antiarrhythmic drug can cause dysrhythmias. So ablation, catheter ablation of atrial fibrillation. Indications. Now, this was the indications before. This is probably going to change. Is present symptomatic atrial fibrillation is refractory or intolerant to at least one class or class 3 antiarrhythmic drugs. Selected symptomatic patients with CHF, reduced ejection fraction, or both. Is performed, here it is the key. Symptom relief and improvement in quality of life. And we'll talk about this. FDA is also approved for paroxysmal atrial fibrillation lasting less than 1 week, but ablation procedures are also performed for persistent atrial fibrillation greater than a week or permanent atrial fibrillation greater than 1 year. All right, so this is the important thing, and you can talk to your patients, is if they can get ablated and they get back to normal heart rhythm, they feel better. Remember, we want our patients to feel better, and they take less medications, and they have less medications with side effects in them. They feel better. They'll tell you after the ablation, they feel normal again. They don't have that shortness of breath, that weakness. Someone said, I was so weak, I had trouble getting out of bed. I had the ablation, and I felt better. That's the whole key. This is why we do medicine, is to get people better. Anticoagulation for 6 weeks prior to procedure, or TE showing no atrial thrombus. So these are indications for this. Our success rate with these, with ablations, is 80 to 85%. Much higher in atrial flutter, but these numbers are going to get better as we get better at the technology. Now let's talk about the complications. Cardiac tamponade, and you'd have to, 1.3%, you need to reverse anticoagulation and do a pericardiocentesis. Stroke, 2%. You can have pulmonary artery vein stenosis and phrenic nerve injury. Esophageal injury with ulceration, atrioesophageal fissures. With the new technology, these are less likely to occur. This is a big change. These complications are going to go away, so we're going to have more of a plus side and less of a negative side over time because the technology has gotten better in a catheter ablation for atrial fibrillation. Follow-up procedure, oral anticoagulation should be continued at least 2 months after ablation. Then after that, it should be based on their CHADS VAS score. Antiarrhythmic therapy for 2 to 3 months after the procedure. Event monitor for several months after the procedure, including a 24-hour Holter monitor every 2 to 3 months for at least 2 years. So it's not perfect, but the technology is getting better. Now let's talk about the left atrial appendage. Now, what is the left atrial appendage? It's a small pouch, it's finger-like. We looked at the other picture over there, and we saw it's kind of a blind-ended muscular pouch, kind of like a little finger sticking off the left atrium. It's from embryonically, it's from our embryo stages, and it's at the right and left atrium, and it has a complex trabeculated inner structure. It plays a role in modulating our left atrial pressure and volume. It can secrete ANP, atrial natriuretic peptide, causing cardiac hemodynamics and volume hemostasis. The thrombus originating in the left atrial appendage counts for 90% of our atrial fibrillation related strokes. So it's very important. During atrial fibrillation, there's hypocontractibility of the left atrial appendage, causing stagnation of blood flow into the trabeculated cavity. So you can do surgical ligation of the left atrial appendage. And the data of an instance of an embolic event. So if we take out the left atrial appendage, ligation means we cut it off. And there's different devices that can be used, some to kind of block the hole, and there's devices that can cut off. And there's different devices that are being worked through the FDA. So you reduce your clots by, you have 3% clots. So you take out the left atrial appendage, you either block it or you take it out, 3% of embolic events. Versus you don't do any ligation, you can have 17%. So it can be a big difference. Now, does that mean it's a perfect at ligation? No. Now, it is very important, the left atrial appendage, because it's predominant site of atrial thrombus in patients with atrial fibrillation, accounting for the majority of cardiac emboli in this population. It's due to blood stasis and reduced contractibility in the appendage during atrial fibrillation. You need to use a transesophageal echocardiogram is essential to look at the left atrial appendage. A transthoracic, where you're going across the chest, it's not going to work. It's not going to give you the data that you need. Now let's talk about digoxin. Digoxin we discussed in several different arrhythmias that can induce that. Now, toxicity is associated with serum digoxin levels greater than 2, although symptoms can occur at lower levels, especially those with predisposing factors. Low body weight, advanced age. Who's going to be taking this? People who are advanced age who may have low body weights, impaired renal function. Remember, our renal function gets worse as we get older. Hypokalemia, hypercalcemia, and hypomagnesia. Hypokalemia notably increases the risk for adverse events. Hyperkalemia may also occur with severe overdose, particularly with impaired renal function. AKI impairs digoxin clearance. So just think about it. If you have an old person that's been taking, an older person who's not big muscle mass, small mass, and they've been taking digoxin for years, they get a flu. They have nausea, vomiting, and diarrhea, so they have low PO intake, and they're having low blood flow to their kidneys because they're hypovolemic, so they're going to have an AKI. So that medication builds up because if it's excreted by the kidneys, you put it in the body, it doesn't get peed out, so it builds up in the body. GI symptoms can be anorexia, nausea, vomiting, abdominal pain. Visual symptoms, you can have changes in color vision, sclerotomas, and blindness. Now, the famous people like to discuss is that the painting by Van Gogh of Starry Nights is an example of what digitoxicity looks like. Cardiac, you have bradycardia, AV blocks, as we discuss, ventral tachycardia. It does not correlate with symptom digoxin levels, clinical presentation, and EKG findings. So this is a clinical diagnosis. It does not correlate with levels. It does not correlate. It correlates with clinical presentation and EKG findings. So this can be a tough diagnosis to make. Treatment is what? Digoxin-specific antibody fragments. And they can be expensive, but there really is no treatment. We can dialyze them, right? We can put it in a catheter and dialyze them. No, HT is ineffective. The molecular weight and large volume distribution makes HT ineffective. All right, now let's talk about a 67-year-old with past medical history of atrial fibrillation. The BMI is high. This is in Oklahoma media. This is a 58.4. And she's in a nursing home. She falls off the bed. And she's on a heparin drip, okay? We have multiple women that are falling off the bed. They're all the same. They're all twins and they're falling off the bed. One's on a heparin drip, one's on a enoxaparin, subcutaneous, one's on a DOAC. And they're both all noted for hypotension. So all of them had a cardiac cath or they had an HD cath. So when we talk about going into the femoral region with a cardiac cath, we can have increased risk of a retroperitoneal bleed. The same thing can happen if somebody has an HD catheter placed. The HD catheters are large size, like the size of this pinky going there. And sometimes they can go through the artery and cause a bleed. Or it can be an AV fistula between arterial and venous fistula, can go through there and cause a bleed and cause a retroperitoneal bleed. And that happens. So here's an example on here in the imaging of a retroperitoneal bleed. This is a large one. So blood enters into space immediately behind the posterior, reflecting the abdominal peritoneum. So what's there? The inferior vena cava, the kidneys, ureters, adrenals, rectum, parts of the duodenum, parts of the pancreas. Remember the tail of the pancreas, parts of the colon. Now, 22 to 36% of this is from trauma. These ladies unfortunately fell out of their bed in a nursing home trauma. Spontaneous can occur in less than 6%. So what do? We got to stop the bleeding. Now, if you call somebody to fix this, they're really not going to be too interested. Surgery's not going to want to get in there because it's a difficult space for them to work in. IR, unless they can find an active bleed, is really not going to go after it. So we have to stop the bleeding. We have to stop the bleeding medically. We're going to talk about this real quick, and then we're going to go back to that case. So if someone falls, should we hold anticoagulation? Now, this is going to have to be an individual by individual decision, meaning the individual provider is going to have to sit and talk to the individual patient, and they're going to have to come to an agreement. Because there's several studies which show this, that risk of falls does not significantly affect major bleeds. Risk of falls does not, now that does not seem intuitive, does it? It seems like if you fall more, you have if you have a higher risk of fall, you're going to have increased risk of bleeds. Both bleeding and thrombotic events increase sharply with advanced age. But in these studies, this is a kind of a landmark study. It was done a long time ago. And it shows need to fall greater than 295 times to outweigh one subdural hemorrhage. So it's a discussion in N01. If this patient has falls and are in anticoagulation, do you continue or not? That discussion is an N01 with one provider and one patient meeting together to come with a decision. We're back to our regularly scheduled program of managing a retroperitoneal bleed. So what is the etiology of the bleed? So we already know ours is with the retroperitoneal bleed. We need evaluation labs and imaging, which we have. And then the treatment is going to be based off, remember we had 3 people. We had 3 triplets that have fallen and they have taken different medications. So the one that's on the heparin drip, we use protanamine sulfate. Protanamine sulfate works great. Protanamine sulfate can reverse this. And I'll give you an example when we're done of how excellent of a job protanamine sulfate can do. Enoxaparin doesn't get reversed that well. I'm sorry, it doesn't. It's a good drug, it's hard to reverse. Protanamine doesn't do a great job. You can try recombinant active factor 7A. Now this is a vitamin K dependent glycoprotein, which is produced by recombinant DNA technology. Once I say these things, you know it's going to be expensive. It's going to be expensive. So it's expensive. This is used for hemophilia A or B. It can also be used for factor 7 deficiency. And yes, you can use this. It depends if your facility has this or not. For DOACs, except the Bigatran and Exisate Alpha specifically for DOACs. But you know what can be used? Is 4-factor prothrombin complex concentrate, which can be also used for warfarin. You can use 4-factor prothrombin complex concentrate, and vitamin K gets used with it. Now, dabigatran or dabigatran, it can be enunciated either way. Idarucizumab, like I said, I think they do this on purpose to make it where you just stick with their drug, the brand name, instead of saying idarucizumab. I even said that wrong the second time. That can be used for reversal. That's specifically made for dabigatran or dabigatran, depending how you enunciate it. Now, I can give you an example of how heparin works so well for protanamine sulfate. I had a young man who happened to have atrial fibrillation after he just recently had a fresh spinal surgery. And all the disciplines got together, the neurosurgery, the cardiothoracic surgeons, and then the cardiologists got together. And they said, what can we do for this patient? And they said, we were okay with starting a heparin drip. The neurosurgeon was okay with it. And he just didn't want a bolus. That was his thing. He didn't want a bolus. Well, he got a bolus. A young nurse made a mistake and bolused the whole bag of heparin. And as this patient was brought over to the ICU, we called to the pharmacist, and we had a great pharmacist, one of the greatest pharmacists in the world, bless her soul, who was able to get the protanamine sulfate to us in rapid time period. So within 6 hours, we were able to reverse this whole bag of heparin, and the patient had no complications. So heparin and protanamine sulfate work well together. Enoxaparin, it doesn't work as well. So remember, our triplets that fell in this nursing home with 3 different anticoagulations, we have to first figure out, is there a bleed, getting our labs, getting our imaging, and then work to reverse it. These retroperitoneal bleeds, it's hard to get someone to come in and help you unless there's an active bleed that's noted on imaging.